The original NHIF was National Hospital Insurance Fund. That is what started way back, I think, 1968. And the whole purpose of that was for people who are on employment to make a contribution to this fund so that when they're admitted in hospitals, then the fund pays for them.
Hello, welcome. Karibu to the One Health Lens podcast. I'm your host, Dr. Diana Wangari Gitao.
And I am Dr. Simon Moshara Kigondu.
In this podcast, we talk about everything health from global perspective, health matters, and the road to universal health coverage. Today, we have a very important guest, a guest who I must say I have been secretly following. And mostly because he has been quite vocal on the fact that we need to separate the politics behind the road to universal health coverage and focus on service delivery. So today, we're asking him not so much about concerns, but what he proposes as the solutions. Karibu Mheshimiwa.
Thank you very much.
You can start by introducing yourself.
I'm Dr. James Nyikal. I'm a pediatrician by training, but currently I'm in politics. I'm a member of a Parliament National Assembly representing Seme constituency in Kisumu County. And I'm now doing my third term. In Parliament, I'm also a member of the Health Committee. In the past, I've worked in the health sector, been a medical officer offering services in our hospitals in the rural areas. I've been a director of medical services and was also a permanent secretary in the Ministry of Public Health and Sanitation. And I was also a lecturer at Nairobi University in the Department of Pediatrics. And I've also been in the doctors' movements. I was a chair of the Kenya Medical Association and a member of the Medical Practitioner Dentist Board, which is now called the Medical Practitioner Dentist Council. So that basically is my background.
Well, Kigondo, we found someone who has more experience.
Yeah, so far I've been monopolizing the experience, but now today Honorable Nyikal has more experience than me. He's actually my mentor. In the year 2000, when he was chairman, I was chairman of KMA Machakos division, and he mentored me. So that's why 23 years later, I'm the president.
That's a credit to him.
And also that time there's something we did.
Yes.
We actually brought together the medical associations in East Africa, Kenya, Uganda and Tanzania, and created what we wanted, a federation of medical associations of East Africa, which actually worked briefly. But it brought forth something that is still going on, which was the mutual recognition of the doctors trained in the three countries, and therefore the regulation of doctors across the three areas, which has actually now moved to the whole of Central Africa, so that the regulatory authorities of East and Central Africa actually come together to look so that they have the same training syllabus, the same curricula, and the quality of training.
Thank you.
That is still going on. And we were with him when that started.
I should say on behalf of the medical community, thank you. Tell you, I think the very important question is, we seem to be focusing on a singular aspect when it comes to universal health coverage. Thus far, most people have been having a conversation on there's going to be 2.75%, right, percent deducted. And that has been the constant headline, right? This is the cost. There's no real conversation, a holistic conversation of saying, okay, fine. Beyond the contributions, we are starting from somewhere, right? There's NHIF as it is. There's Social Health Insurance Fund as we envision. There's a gap in there, right? Maybe let's start from the past. what the history of NHIF and how you see it transitioning to social health insurance fund, right? Because most people are saying that beyond that, are people going to be jobless at NHIF? What's going to happen to the managed schemes, right? All these are headlines that is distracting from service delivery, right? Yet again, we need to focus on service delivery. So take us from the history to just that transition period. Yeah.
Well, I mean, we start with this the history of NHIF. So let's start by saying, what is NHIF? The original NHIF was National Hospital Insurance Fund. That is what started way back, I think, 1968. And the whole purpose of that was for people who are on employment to make a contribution to this fund, so that when they're admitted in hospitals, then the fund pays for them. Remember, they were just people who are in employment, regular employment. At that time, what it was doing was actually paying what was called rebate, basically paying for the beds. So definitely it had a deficiency, because when you go to hospital, the bed charges is not the only. You don't sleep there.
And get better.
Get better.
Yes.
So it was realized that it wasn't actually covering surgery, for example. It's not covering drugs. It was not covering investigations. It was not covering consultation by doctors. So to that extent, it was very deficient. And therefore, there was a move around 2000 to actually make sure that it covers more. The first attempt was actually to just increase the rebate in the hope that if the rebate is made bigger, it will cover all this. Unfortunately, by human nature, when that was done, the hospital bed cost went up and
of
consumed
course.
that whole rebate without
natural
cover.
Yes.
So later on, this led to the desire that we should increase, involve other things, and it also went with the desire to change the name from hospital to health, so that we create a National Health Insurance Fund. At that time, now we started to say this is a health insurance fund, and then we were saying define the benefits that you get by having this health insurance fund. And at that time, it was we started defining what else can it do apart from paying for beds. So actually, benefit packages were included. I think like surgery was some surgery was included. Some investigations were included, like X-rays, CT scans, later on even MRI. But this had to be defined. It was then realized that it worked relatively well, but the contribution was to a large extent still for people who are on employment. So it was felt that there are people who are not employed and may also want to benefit from this. And then it was said that we'll have voluntary contributions. So voluntary contributions were brought in, I think about 2002 and so on. And this meant that people were paying, and I think a minimum for families came to about 500. I think other figures,
500. Yeah.
Other figures were also tried. And then, but it came with an issue that voluntary contribution, the people who are making their own decision to contribute, would decide to contribute when they already know they have some illness.
Yes.
And so the concept of insurance then was revoked. And you have what was called adverse selection, which means you are just insuring people already sick. It is like insuring a car that already have an accident and you don't know. So it will mean the claim will be more than 100%. It came out clearly, and I was in the board then, and when the figures were done, it was clear that we are paying more for the people on voluntary scheme. We are paying more than the money they were bringing in. So that was not a very wise thing to do. Then there was an attempt around 2004, 2005 to now broaden it and do what is called social health insurance. Now, social health insurance by concept means that everybody in the country is to pay.
Okay.
And people pay according to their income and get services according to their need and bring the concept of solidarity. This is actually the original concept that was actually in Germany. That's where it all started. So there was actually, it was called NISHIF, National Social Health Insurance Fund.
Yeah.
Actually, a bill was then put to that extent that actually passed through Parliament, but was not accented to by the President. And the reason why the President did accent to it, with President Kibaki at the time, the concept was that everybody pays. So the question came, there are those who can afford, and there are those who definitely cannot afford.
Yes.
They are called the indigents.
Yes.
So it was asked, how many people are indigents in the country? What's the population? When the figures were worked out, it was so large that the government felt not pay. So they didn't.
Yeah.
So that did not then work.
Yeah.
So many efforts were now being made to pull all the monies under NHIF.
Yes.
Then the NISHIF thing didn't work. And that is when there was now an effort that you will find that people who are employed and paying NHIF, they also have some medical schemes. So their employers were also paying insurance. A different, sometimes private insurance for them. So the question say, why don't we pool the health? So in the private sector, that went on. And even up to now, even when we go on, people will pay NHIF and still have private insurance.
Yes.
But for those in government employment, particularly I think the police, the civil servants, it was decided the money that is being used for their medical scheme, why don't we bring it into NHIF?
Yes.
And so that NHIF can give them more benefits. It was called an enhanced scheme. And so that we bring that together. And it was actually salary based. Because these people, a part of their remuneration was called their medical cover, which was then being put in this scheme. So when it was brought in many cases, their medical cover was now removed. And that brought an issue. That it didn't bring an issue because initially it worked well and they were getting enhanced services. When, again, the figures were done, it turned out that this medical scheme, like civil servant scheme, like the police scheme, what was being paid out for their enhanced services was much larger than the lump sum premium they paid. The question there was, and still is, was there a proper actuarial assessment of what they should pay? So the actuaries... that is not answered. But what ended up is that it was decided as we are now moving on that now we remove those schemes. What I don't like is that when these schemes moved and they went back to the private sector, the lump sum premium they were paying to NHIF is much smaller than when they are paying when they are now paying to the private sector. So we have a problem in the country where there's a bit of lack of sincerity and commitment to national causes. So it is around this time, actually, that there have also been issues, a lot of issues of integrity. There are fraud. There's definitely fraud in all insurance schemes. There were big frauds. And because of this, it was felt that maybe another approach is needed, and that is when the SHIF concept came in.
Again, maybe just to even take you back so that we don't lose the audience, right? Amongst us, we might understand the premium element contribution, but maybe to go back, right? So you say that, say the civil servant scheme, for example, right? What was discovered when they were under NHIF was that what they were, the deductions that was coming out of their paychecks, right? Versus what was being, what was being expensed was much more. Is that it, or there is a difference?
What is it is that there was a deduction that was being done and was going into their scheme. Now, their scheme had a huge amount of money now.
Yes.
But their schemes then went into arrangement, discussions with NHIF, and said, if we pay you this lump sum, will you give cover to all our people?
Okay.
The answer was then yes.
Okay.
When they paid that lump sum to NHIF, and NHIF started giving these enhanced services. When NHIF done its mathematics, it found that it was spending more than the lump sum that was given. So the question there was the calculation of the lump sum premium. I think, and that's where the problem came. But when now you removed it, then the like in this shift you are removing it, it's not there. Then the question will come now. Do they continue with their private insurance out and you continue their deduction? If you don't, then you have actually, in a way, interfered with their remuneration because they are paying for that lump sum and you are not allowing it. As currently what is going on, I think there is an attempt to use that lump sum to go into the private sector, which is again fragmentation of the pooling system. So again, it's a management issue. And when you see why I think there's lack of sincerity, how come that when they were going to pay to NHIF, the money they agreed to pay is smaller than when now they have left NHIF and going to pay to the private sector? So that's the issue. So that's now when we came to the issue of shift now. But you also, there's a word that is also thrown around called UHC. So now, what is UHC before we go to shift? Because everybody has been convinced that the route to UHC is shift.
Absolutely. That's all we know.
So now let's say, where does UHC come from and what is it? Let me start by telling you what UHC is. This is, it was a WHO-driven initiative which says all countries must make arrangements so that all the citizens will get health cover without catastrophic payments at the time of delivery of services. Which means, at best, they should not be paying, but arrangements should be made. And one of the arrangements is social health insurance. And so when that, you may not realize, but that WHO move came from this country.
Is it?
Yes. When the president declined to assent to National Hospital Insurance Fund.
2005.
Yes. It was me and with the Honorable Ngilu. We made a presentation at WHO on the 2004 World Health Assembly. And we said that social health insurance is a good way to go to ensure that all citizens get health cover without paying directly from their pocket. It was already working in countries like Germany. We have a form of it in NHIF which was not working well. Countries like Thailand was trying it out. So we said it should be made universal. So, but the countries like the US, which goes, health is almost totally private, and Britain, where health is paid for by the government, said we cannot insist on social health insurance principle and force it upon all countries. So the agreement was, what was now agreed, just say every country must put in places, including systems like social health insurance, to ensure that every citizen gets health cover that they can afford. Hence, universal cover. Universal health cover. We didn't run away with it. Other countries ran away with it, and it has worked in other countries. Now we are still talking about it, and now we are trying to use SHIF to do it.
Yes.
Now let me tell you what it is. Universal health cover simply means there are health services that are working and that every citizen can access them.
Absolutely.
Now, what is SHIF doing? And why do we think it is going to give us universal health cover? SHIF is addressing healthcare financing.
Absolutely.
So we are going to collect a huge amount of money from everybody at 2.75 without a cap. So that if you are earning something like 100,000, you will be paying, is it 2,750? Yes. Yeah. If you are earning $1 million, you will be paying 27,000 per month.
Yes.
So we then going to pull that money.
Yes.
Then the question that we should ask in SHIF then, what about people who are not employed? So the bill proposes that people who are not employed will also pay 2.75 of their income. Now, how are we going to determine that income?
Exactly.
Yeah. So that is that we said we are going to do a means test on all the people who are in formal employment.
What's a means test?
Now, do a means test is assess the families and see what is their level of income.
But then how do you assess that?
That is that is the system called means test. So basically what you should do is then go to every household that is not on formal employment, assess, because if you go into a household, it is possible to assess their income.
Yes.
First of all, just by a questionnaire. Yeah. If the head of the household, if there are two people working, how much are you earning? And then look at the house. What is the kind of house you are staying in? Yes. What is the kind of transport you use? What is the so by using that you can assess and levy that you are going to pay this. Your income level is this, more or less like a tax system.
But we haven't even done that.
Now you are getting to the gist of the matter, why there's a lot of hype.
So
now, then there's another group. Those are people who are in formal employment, have an income. Yes. What about those people who actually are not able to? So this means testing should also tell you these people are totally unable to pay, so we are going to pay for them. And as this health improves, this will be done at county level. So the county government and the national government will apportion on who pays for the indigents. Now, but what we are keen on now is on people who are earning salary, because that is easy to do.
These means tests, should it be done only because we have a new SHIF, or should it be done to, I hear it is done by Kenya Bureau of Standards, but who will cost, who will pay for the means testing? And that sounds like a huge exercise. And this data, will it only be for health? And will it be done at a national level or at a county level?
Already
pay for it.
Already in some counties, you remember the counties that had the pilot. Yes. The pilot counties actually attempted to do this means testing. Okay. So it can be done at a county. In fact, it would be better be done at a county level. But there definitely must be national support. Yes. Yeah. But that is one of the things that has not come out. How are you going to do the means testing? Exactly. And then, even if you do the means testing and then you say, this household is earning 100,000 a month, so they should pay 2,750. This one is earning 500,000, so she should pay about 13,000 something. Yes. And this one is $1 million. They should pay this. Now, how are you going to collect that money? That has not come out. Now, the ones that when you decide they are not able to pay, it is the proposal here is county government and national government will pay for them. So that is a gray, that's an area that is not really gray. They have said how that it should be done. It is the details that are not issue. And it comes to something you said.
Yes.
There's a lot of hype on television and everything.
Yes.
But I don't feel work on the ground that is working on that.
Absolutely.
Now, he's asked whether we are doing this just for shift. Means testing is not only used in assessing what you should pay for health insurance or whether you should be exempted and paid for by the government, but means testing will also be, look, we are saying with university education, we say that there are students we are going to pay for at different levels. And if you go to that document, there is also a mention of means testing to know what should be given to what students depending on the income level of their family.
Yes.
So if you are working in a coordinated manner, the means testing that is for health could also be used in education.
Yes.
Right now, the only ministry that I know has been doing this means testing is the Ministry of Social, Ministry of Labor with Social Protection, where the means testing was used to get funds for the elderly person's cash transfer. Yes.
So moving on now to this SHA, Social Health Authority, and ask generally, I want you to comment quickly on several things. One, why revoke NHIF? Secondly, why re-register anew when there are already systems in place for identification and all? Why accredit anew, and how long will that take? We already know how difficult it is to accredit this. So, because now we have overhauled NHIF, can you...
These are policy issues, and governments do make policies. Governments start by coming from parties or coalitions that fight it out in the political arena to get to power, whether they get it through the vote or by some other means, but they get there anyway.
They get there.
They get there anyway. But so then they tell the people, these are the things we are going to do, and they say they are going to reorganize. I think the word was to reorganize NHIF so that it can give us as be a vehicle for UHC.
Yes.
And so they decided that you are bringing this act, and this act is repealing NHIF. The premise in my mind is they were saying that NHIF was just for people in employment, which is not really true, because it had started giving provisions for people in informal employment and so on. But they've said now it's going to be totally for everybody. Two, NHIF had a cap, which means I think it was something like 1,750. That was the cap then. Yes. So that people who are earning a lot of money were relatively paying less. Yes. Because after the cap, they kept paying. So if the cap was at, say, 40,000, then even if you are earning $1 million, you pay that. So they say without cap, it covers everybody. And then the other issue they have been saying is the management of NHIF was so bad that they need a new institution altogether. I'm telling you what they're saying. I'm not telling you what I believe. I don't believe without the cap. Yes, because that has come into the law. But even now, when they are talking, they're indicating that when the regulations come, and they brought the regulations, then they can now talk about the cap. So to me, and I'm biased because I felt that this new act needed not, even if it was going to take over from NHIF, needed not to be so drastic in certain area where they actually, like employees, leave all of them out and then start employing
from zero.
That transition arrangement I thought was not good. And now when we are going into now the details of implementation, we find that the registration, they are going to throw out all the old registration. They are going to throw out all the old empanelment.
What do you mean? So all hospitals start
all
afresh,
those people,
everything?
Yes, that's what they're saying in this. But we don't know how that is going to be done. They have a transition of 1 year.
Wait, so in 1 year we register all hospitals, we get employees to transition or to get into shift, all this in 1 year.
And not only that, all people have to be registered anew in NHIF. So what we have, all people, and that's what the minister said, they'll start in March. I don't, it looks very difficult. I don't think it will be feasible to register all people, register all new hospitals, and register the new claim system. And so that I have an issue with that because it's a good thing that we may implement badly.
It's really
even the board itself. Now you have a new chair and a new board. Yes, but the old chair and the old board is there. They are in transition. I'm given to understand that they have put a transition team, which is supposed to do all these things within 1 year. So I have a problem with the transition arrangement. I think the transition arrangement is a major challenge. I would have gone for a more gradual transition arrangement. I would take in all the staff and then attrition them as the new organization wishes. Yes. I would have taken all the registered people and then clean the register. That's what we would have done. But they've chosen to do
drastic measures.
To do those drastic measures. We don't know how well. But I also have another issue with it in the act itself, is the claim system. Now, before, they had a claim system which they said was beset with and it's true, there was actually a lot of fraud. I mean, the health committee, and there have been issues of fraud that we are investigating. There were hospitals that were making false claims, claiming surgeries that they have not done, and therefore they have now established we have now established in the new act a claims office. But this claims office is now, the law has given provision that it can now outsource claims to other registered insurance companies. Now, my problem with that is that claims is the major thing. So we are saying that the people we have in NHIF, even the people we are going to recruit, we cannot really trust them to do the claim, and so we outsource the claims. Now, I don't know how that will work, but claims is a major component,
a very big one,
of insurance. So that is another major change in this thing.
Okay, so I laugh.
So I'm concerned.
I know I am
concerned. And then that is just about collection of money, and then empaneling health providers to give the service, and then making the claims to pay them. There's one thing we have to touch.
The patients themselves services. Receiving
the
services.
Because this is money to buy the services.
Exactly.
Where are the arrangements to make the services available?
Absolutely. We haven't had at all.
Now, that we are not talking. It's not only SHIF. It's not the only bill that was enacted into law. There was also
Facility
FIF.
Improvement Fund.
That we are not hearing much about.
We haven't had at all.
There was also the primary
healthcare
fund. The digitization we are not working along. But the digitization, I can see an input coming in here. Because even this registration, this empowerment, this claim is going to have a new digital platform. But that is just for now. What about the digitization in the health facilities? Because you cannot digitize this if the facilities. So my major concern, FIF Act was doing two things. One, it is bringing autonomy so that the funds that the facilities get will be managed within the facility. It is also proposing management structures for those facilities.
Yes.
I like that because at least now that is touching on health, on improvement of the services.
Yes.
Because the facilities are the facilities, the facilities, they are the equipment, they are the human resource,
Yes.
then they're the supplies.
Yes. Yes.
So, but we have a situation here where actually the bulk of that in the public sector is actually with the county government.
It is.
So I'm not hearing much
Yes.
of a preparation at the
county level.
government level. We are hearing much about chief
Yes.
and the collection of money. We are not hearing about the preparation. I was telling our colleague here, it's
Yes.
like you are creating money
Yes.
to pay people with bananas, but you are not helping people to go grow bananas. So that
Absolutely.
So I think as we are moving along,
Yes.
there's this important component of benefit packages,
Yes.
costing, and tariffs. So can you
Okay.
put some thoughts into that?
it is simple, really. We have said the concept is simple.
Yes.
A simple concept
Yes.
may be very difficult to implement, but this one it is possible. Chief will collect money.
Yes.
Chief will buy health services from health providers,
Yes.
which could be facilities or individual providers. Therefore, for the money they are putting, what is it they are going to buy? That is what is called the benefit.
Yes.
The regulations has attempted to define the benefits at level 2, level 3, across the levels, so that they are defined in this. Now, you now know the benefit, but this chief is going to buy those benefits for the people,
Yes.
members.
Yes.
So those benefits must have their cost.
Yes.
And it is that cost that they're calling
Tariffs.
So what they are doing in this, what is being done in this is actually there is a benefit that they have listed out, but they have also created benefits and a benefit package and tariff advisory committee or panel. It's a panel. Now, presumably, it is going to say these benefit packages,
Yes.
they cost this much, and this is what we are going to pay for them.
Okay.
They can say, for example, in level 2, which was what used to be a dispensary,
Yes.
will treat you for malaria, and it will include doing a test for your malaria, it examining you and knowing your malaria, and then giving you the drugs.
Yes.
That will cost this much, and we will pay level
Level
for that for that amount of money. And you see, this chief, there is the one that is being collected, but the primary health care one and the critical and emergency are coming from the taxes.
Yes.
So that pool will still be here. It will still be here. So it is only when they are paying they will say which one are they paying for where, from what we are being here. I don't know the exact arrangements they have made. So then you will say, when you go to level 4, in facilities, a cesarean section is going to be done. And the cesarean section is going to cost this much.
Yes.
So chief will pay that much for that thing. Or you have a normal delivery. A normal delivery will cost this much.
Yes.
And that we are going to pay. You need a CT scan when you go to level 4 or level 3. And chief is going to pay so much for a CT scan. When you go to level 5, you need the dialysis. And so chief is going to pay this much for dialysis. Now, that tariff, my question is, that is a chief tariff.
Yes.
But chief is not the only financier here. There is the private insurance. There is actually direct money that is paid by people.
Yes, out of
People who have a
pocket.
lot of money will pay. So mine was the tariff at a policy level should be linked to a cost of care, so that you have cost of care schedules. Now, they have put this panel. I hope that this panel, what it is going to do is just for chief, or it is for the country, which means if they say cesarean section is this much, then
everyone
whether it is a
30.
private sector, whether it is a private insurance, will pay that much. Whether you are paying yourself, you will pay that much.
So it is not like that. It is not like that. The way they have structured it is that costing was actually being done by the Ministry of Health. There was a department that was going out, and as you had put it, you had done some form of costing yourself. So this tariff, as I understand it, is based on how much money they have budgeted for, and therefore how much chief will pay. It may not necessarily be the cost of care, it is what chief will pay. And it is said that then, because that may not be enough for that particular service, then copay may be allowed. So that's the context.
You see, if you are saying, then you are now getting to an area where the concept of UHC may not work.
It won't.
Because if you have a tariff and you are paying according to that tariff, then then even government hospitals will say, if that is chief what pays, then the cost that is not covered,
you
the
still
patient
have
has
to pay.
So then you will not have. So if you have co-pay, then that is a big erosion of the whole concept of UHC. Now, then there's an issue that will come. What about private facilities?
Exactly.
What about private insurance? Will they be bound by the tariff that is in it?
No,
and it's
the
not
explanation is that when a service is, if chief pays less, then you are allowed to copay.
Yeah, okay. If then you are allowed to copay, then there is, for me, what I believed, and I tried it when I was in KMA and this, that we should, as a country, work on the cost of care and give a tariff on payment. Remember when we in KMA, we tried to put a schedule of doctors' fee.
Yes.
Yeah, there's a schedule of doctors' fees that was done. Now, cost of care is not just the doctor's fee. What constitutes the cost of care? If as a patient you walk in a facility to look for health care, there will be the consultation that will be there. Then there will be investigations. Consultation will include the examination they are doing, the temperature they are taking, those triage things. That is the consultation. And then the investigation that is done, and if there's a procedure like surgery, that will be the cost of care. If you are admitted, then the bed capacity. So if you're going to look at cost of care, you must look at the doctor's fee for a surgery. That is one. The consultation, that is another one. The investigations, that is another one. The hospital bed, if you're admitted, that is another one.
Any consumables.
Any consumables that are used, those is another one. Drugs, those are another one. And therefore, I don't know whether these benefits and tariff advisory panel will do it
that work
for the whole country, so that even the private sector, because we will have a problem of saying healthcare is expensive. If we want to bring it down and looking at socially, like UHC is a social approach, then we must look at the cost. And we must even get the private sector. We must get the doctors.
Absolutely.
We must get the pharmacists. We must get the people who do x-rays. And then they sit down and say, this, it will be a huge, all tariffs are huge documents, which is saying this is what it is. So I don't know. When I see people talking a lot on TV, I don't know whether there's an equal amount of work going on in the background
that we're not aware of.
That we are not aware of.
I mean, it sounds like And most of this conversation, I've just been listening because I feel overwhelmed just from the conversation, right? Because despite even the little knowledge that I might have, what it's appearing is it's more about the grandiosity of it, right? That we're going to be able to offer care to everybody, right? We're going to be able to cover it through part it's contributory, part is tax funded, right? But the mechanisms behind it is not clear. Because if we are overhauling everything, right, within 1 year, there is no way we're going to manage that. It takes decades to even change, say, even just a system in itself.
That started in 1968.
I mean, the experience you have, by the time you're getting to 2005, right, that experience cannot be condensed to 1 year. It cannot be condensed in a way that first service delivery is top, right? Because then what I'm seeing as you're speaking, right, we'll have a pot of money. Then people are going to come to a facility, a level 2 facility, which used to take maybe 50 people. They have now heard that they can get care. They'll come, the 50 will become 200, 250. Then what? Because we haven't covered the basics, right? So how, I mean...
the whole, you see, what I told you was that I'm a politician, but sometimes I find politics extremely naive. It's just good at getting votes.
Yes.
But you know, getting votes is totally different from delivering services. Let me tell you, getting votes, you can be good, you look nice, you say nice things, people sing, you can give them handouts, you can now come with colored motorcade and so on.
Yes.
It is a one event thing. At the end of that, you got the votes, you have won, or you rigged, whichever way, but you are there. But now when it comes to service delivery, then you have to change. You said we are going to give you free health care, universal health care based on social health insurance. That's just a 5-minute thing. But then when you go, and now we are just dealing with the act. So you get the money.
Yes.
We are focusing so much on getting the money, and I think we'll get money. The people who are employed are large enough. There are captive contributors. They will contribute wapende wasipende. So money will be there.
Yes.
I'm not so sure we will be efficient in getting money from the informal sector. I'm not so sure we will actually accurately get the people who need to the government to pay for them, and who will pay even if you have to do it gradually, because you may not.
Absolutely.
But the bigger thing
is the
how are we preparing the services?
I hear you, Dr. Nyikal. I hear you. I hear you. I am worried. I am concerned. I am concerned. I think we need to have this conversation again and distill it.
I'll tell you what I would like to hear now.
Yes.
I've had
as
enough,
the final word.
I've had enough
Yes.
from the minister and the president on their good intentions.
Yes.
I now want to hear more from the technical people, the director and his people.
Yes.
I want to hear more from the governors on how they're preparing that the county facilities will work.
Yes.
I want to hear more from the county executive officers for health on how they're
Are we
preparing
ready?
level 3, level 4, level 5. We want to hear more how the primary health care money is going to be paid at level 2 and 3. Now, we are not hearing that. We want to hear more.
Yes.
Because we have no more money.
Yeah.
Now we are able to treat more people.
Yes.
I want to hear more about how many doctors are going to be employed.
We
how
have
many
more
nurses
questions
are going
after this. We have questions on questions. I think this is the first episode where I've been left with more questions than answers. More questions than answers.
Yeah.
Really. Thank you so much, Mheshimiwa Kigundu. There's a list of people we need to answer all these questions, because it seems on the road to universal health coverage, we need a lot of work. Thank you so much for joining us, and we'll see you next time.